Hello everyone, welcome to my another video. This video is from the pharmacology section in which we'll be discussing about the drug therapy of glaucoma. Specifically, we'll be discussing about the wide angle glaucoma drug therapy. And in the upcoming videos, we'll be discussing about the narrow angle glaucoma drug therapy. So in this video, we'll focus on the wide angle or the open angle or the chronic simple glaucoma drug therapy. So let's start our discussion. So here's an overview of the two types of glaucoma. The first one, wide angle, which is also called as open angle or chronic simple glaucoma. And the second one, narrow angle or closed angle or acute congestive glaucoma or angle closure glaucoma. So there are different names associated with the same type of glaucoma. So please have a note of it. And we'll be discussing about the wide angle glaucoma in detail in this video. So speaking about the drug therapy associated with wide angle glaucoma. So the drug of first choice in case of wide angle glaucoma will be lansoprazole, which is a prostaglandin F2 alpha analog. Then come the drugs of second choice, that is beta blockers. And inside the beta blocker section we have B1 selective class and the non-selective class. From the B1 selective class, betaxolol is used, which is usually started first. Then from the non-selective class, we have timolol, levobunolol, and levobunolol is the longest acting drug over here. I repeat, please listen it carefully. In case of wide angle glaucoma, the drug of first choice is lansoprazole, which is a prostaglandin F2 alpha analog. And this drug generally increases the uveoscleral outflow and it is efficacious. Then the drug of second choice, beta blockers. And in the class of beta blockers, we have two subclasses, B1 selective class and the non-selective class. So from the B1 selective class, we have betaxolol, which is usually started first in the therapy. And from the non-selective class, we have timolol and levobunolol. And from this class, levobunolol is the longest acting drug. And I have written one question over here, that what happens if they don't work? So what does this mean? This means that in the drug therapy of wide angle glaucoma, if the drug of first choice lansoprazole and the drug of second choice beta blockers both don't work, so what is the third choice left in front of us? So let's try to analyze the third choice. So the third choice is using lansoprazole and beta blockers collectively simultaneously. This means that if separately the drug of first choice and the drug of second choice is not showing any action, then the third choice left to us is using the drug 1, that is the drug of first choice lansoprazole, and the beta blockers, the drug of second choice, collectively. Or one more option is there, that is adding other drugs. So what drugs can we add? Brimonidine, which is alpha 2 selective agent. Then dorzolamide, which is carbonic anhydrase inhibitor. Then dipivefrin, which is a prodrug of epinephrine or adrenaline, and it shows long action. Then comes pilocarpine or physostigmine, and these are the cholinergic drugs. So please go through it for once and have a note of it. Now let's look at the actions. So the drug of first choice lansoprazole is a prostaglandin F2 alpha analog. We already know that. So let's look at its action too. Lansoprazole increases the permeability and the uveoscleral outflow, and it is efficacious too, with no systemic adverse effects. I repeat, lansoprazole increases the permeability and the uveoscleral outflow, with no systemic adverse effects. Then come the beta blockers, and beta blockers generally decreases the aqueous humor formation. Now let's discuss about the actions of the other drugs, which will be used as the third choice if the drug of first choice lansoprazole and the drug of second choice beta blockers are not working. So let's look at them one by one. Brimonidine, it decreases the aqueous humor formation. Dorzolamide, same, it decreases the aqueous humor formation and also it decreases the bicarbonate ion concentration. I repeat, dorzolamide decreases the bicarbonate ion concentration and also the aqueous humor formation. Then dipivefrin, it increases the uveoscleral outflow. Please have a note of it. Dipivefrin increases the uveoscleral outflow. Then it also increases the conductivity of trabecular cells and it decreases the aqueous humor formation. I repeat, dipivefrin increases the uveoscleral outflow and also the conductivity of the trabecular cells, but it decreases the aqueous humor formation. So please have a note of it. And lastly, speaking about the cholinergic drugs, that is pilocarpine and physostigmine. So they act by cholinergic mechanism. Now let's look at some of the important points which we should remember because they are very important from the exam point of view, as questions can be asked from here. So let's look at them one by one. So the PGF2 alpha, that is prostaglandin F2 alpha analog, which is lansoprazole, it increases the permeability and the uveoscleral outflow. We already know that, we already discussed about it. It has no systemic adverse effects, but irritation, pain and burning sensation, and it is quite expensive too. Then come the beta blockers. Betazolol belongs to the B1 selective class, whereas timolol and levobunolol belong to the non-selective class of the beta blockers. Now, the drug from the B1 selective class of beta blocker, that is betazolol, has less systemic adverse effects and it is usually started first, whereas from the non-selective class, timolol is the second choice of drug, or it is used when betazolol ceases response. I repeat, timolol is the second choice of drug, or it is used when betazolol ceases its response. Now speaking about the adverse effects of timolol, there are local and systemic adverse effects in the form of bradycardia, hypotension, heart block and heart failure. And levobunolol is the longest acting drug from the non-selective section of the beta blockers. So that's it for today. In the upcoming video, we'll be discussing about the narrow angle glaucoma drug therapy. So before that, please go through this video for once, make some important notes, and if you are new to my channel, please do subscribe to the Encephalonia. Thank you for watching and stay connected.